Hi, this is Dr. Beals again, and this is the Chapter 38 presentation for week 4. And we're going to be talking about activity and exercise. Here are the objectives we're going to be covering through this part. And as you note down here at the bottom, there are once again highlighted terms which may be new, and these are to emphasize your direct learning. There are also many terms in this chapter that are common to previously studied materials, such as anatomy and physiology. So, those are concepts that you want to be bringing forward from previous semesters and previous learning. So, if you need to go back and review some of those terms or concepts, I would greatly recommend that you do that. So we know that there are many pathological influences on body alignment, mobility, and activity, and those all affect the principles for transfer and positioning of the patients that we take care of. So we use these principles of balance and alignment, and that helps us with safe patient transfers and positioning patients during routine care activities. We know physical activity can do many things for us, including elevating our mood, um, enhancing our attitude. It increases our physical fitness. It helps people to quit smoking and to stay tobacco free. Can also help release endorphins, which are hormones that boost our energy levels. Exercise can be very beneficial in the management of stress, and quality of sleep improves, and it can enhance our self image and self confidence. So, when we say body mechanics, we're talking about the nature of movement. Body alignment is alignment and balance. For example, unsteady patients fall if their center of gravity becomes unbalanced, or a patient may suffer from a friction force or shearing force that occurs when skin is moved in the opposite direction. Our bodies consist of a skeletal and muscle system, which, in tandem with the control by the nervous system, helps us to move. For example, our skeletal system, the joints and the ligaments, tendons, cartilage, and the muscles help us with movement. Muscles also help us with posture, and the nervous system balances that out because it's kind of the control of all of that. The nervous system is also um, responsible for our perception of where our body is at any given times, and that is called proprioception. So, physical activity is any movement that's produced by the skeletal muscles, and the result is energy expenditure. So, we want to promote an active lifestyle for our patients, participation in exercise, whether it be isometric exercise or walking or lifting weights, that can all improve our physical fitness and the maintenance of physical fitness. So, evidence based research has demonstrated that safe patient handling and mobility interventions can really help in reducing overexertion injuries. We replace manual patient handling with safer methods based upon uh, ergonomic principles and helping us with our work tasks to safely handle patients and help their mobility. How we do this is we want to assess patients to determine whether or not we need to use mechanical equipment to safely transfer them or move them. And many states have laws mandating safe patient handling and mobility um, in healthcare agencies such as hospitals and long term care facilities. A comprehensive safe patient handling and mobility program is actually foundational in the United States Department of Veterans Affairs. They use the use of standardized assessment tools can identify a patient's mobility level, and this is evidence-based practice. And examples of those types of tools includes the Banner Mobility Assessment Tool. When we assess our patient, we want to look at their environment, so their patient room and the surroundings in the patient room. We also use algorithms to select the right equipment and the right number of staff to help move patients and help them with their mobility. So, just like the rights of medication, we want to make sure that we're doing the right thing for our patient by choosing assistive devices such as ceiling lifts or gait belts or other types of assistive devices to help our patients with mobility. So, the bedside mobility assessment tool, which is actually in its second iteration, addresses immobility using a very simple measuring component with assessment. And we can determine from this the selection of appropriate equipment to safely mobilize the patient. So, here's an example of the BMAT. And this is most easily used within an electronic health care record, and it can help the patient, help the nurse to test the patient's level of mobility by simple tasks such as the sit and shake or the stretch and point, stand and walk. Then the nurse determines, okay, the response to that task, what's appropriate, and then determines, okay, this patient is, say, a mobility level 1, and we can determine the appropriate mobility from that point in time, whether they need assistive devices, whether or not they should be non weight bearing, and so forth. So, this is an evidence based tool, and it is very helpful in determining patient mobility. Now, also, physical therapists, they can be consulted for patients, but many times they're only consulted for a limited number of patients and at different points during the hospital stay. So that is not our area of expertise, but we do have, um, knowledge in regards to mobility, but we're not specifically trained in those skilled therapy techniques. We can communicate potential risk to other healthcare team members, and by using this BMAT or the mobility assessment, we can appropriately determine the technology that's needed to safely move our patients. And this is especially true when physical therapists aren't available. So we have to rely on our own judgment to move and mobilize patients safely. And we do that by using assessment tools such as this. So, throughout the lifespan, we know that developmental changes will affect factors related to activity and exercise, just like many other patient care situations. So, we have to be knowledgeable on different developmental levels from child, infant, adolescent, adult, to be able to effectively plan care. Take, for example, a newborn infant spine, which is usually flexed and it lacks the curves as an adult. But as the infant grows and that thoracic part of the spine straightens, they start to achieve the normal curvatures that appear that allow for sitting and standing. You'll see that developmental change over time. That's why at the end of toddlerhood, the posture appears less awkward. Um, They have more accentuated curves to the spine, and their musculoskeletal system continues to grow and develop, so that they're better coordinated, and their center of gravity is more in tune to be able to walk without much assistance. Now, a healthy adult also has necessary musculoskeletal development and coordination. We have to have this to be able to carry out our activities of daily living, or our ADLs, and to exercise or to be physically active. But as we age, and with the onset of chronic conditions, this can be a factor as the musculoskeletal system ages. Cartilage becomes less flexible, ligaments become less flexible, and we lose muscle mass. We can see problems with activity or mobility. So we want to create an environment that's conducive to cultural background, and be aware of those education pieces that are specific to that patient's cultural upbringing and cultural preferences. We want to create an environment where it makes it easy for people to exercise, and that's a big component of community health, as communities try to design and support active communities, or communities that enhance the access to, say, fitness classes, or parks, safe walking areas, and access to education. With this social support, we can greatly motivate or encourage the promotion of exercise and physical fitness with a particular community. And we see this can be really beneficial for older adults, um, as they, have changes to their body, and we want to increase their social support system in these community type events. All right, so now we're ready to assess our patient. I already mentioned one evidence based assessment tool that can help the nurse with decisions related to activity and exercise. And as you know by now, this assessment process is comprehensive, it's systematic, and helps us in terms of critical thinking. So we want to make sure that we're making patient-centered clinical decisions, and we're providing safe and effective nursing care. So we'll note many things such as their growth and development, any deviations or chronic healthcare conditions. Just looking at a patient's posture can give us a lot of important information about, are they fatigued, are they malnourished, maybe are they suffering from depression, which a lot of times you'll see poor posture in patients like that, or maybe they're just weak from having a chronic illness. So we use that information to help augment our clinical judgment in making good decisions for our patients and going forward. Now, interesting model that is based upon it's kind of a component of the social theory model that we've already discussed with patient education, and that whole concept of self-efficacy is a trans theoretical model, or TTM. So it's incorporates that concept of self-efficacy, and we can use this model to be able to enhance our patients' our education we give to patients by understanding their internal motivation. Take, for example, a patient that's expressed to us they want to lose weight, and we want to help them enhance their physical activity. So we can determine where they're at in that whole contemplation phase using this trans theoretical model. So, for a patient that is in the pre contemplation stage, uh, they probably don't want to change their behavior in the next 6 months or so. And they may be actually totally unaware that they have a problem. or they are maybe demoralized by previous unsuccessful attempts to change their behavior. Now, compare that to a patient that is in the preparation stage, and that's when the individual is really taking action to change their behavior in the near future, if not in the present. So they have a concrete action plan, such as joining a club, buying a bicycle, buying a treadmill, and asking family members or friends to walk with them, for example. So this is a very helpful model in helping us to determine, at what stage is the patient in, so we can tailor their education and do our best to help them to enhance their self-efficacy. So activity tolerance is defined as the type and amount of exercise or work that a person is able to perform without any undue exertion or injury. We can observe very carefully a patient as they attempt to ambulate, as they complete activities of daily living, such as um, them sitting in the chair, uh, transferring from the bed to the chair, brushing their teeth, participating in their bath. So that gives us all information and data, and can be very, enlightening in terms of assessing our patients' ability for activity and exercise. Or do they get short of breath, for example? Do we notice that their heart rate increases or their blood pressure decreases when they're rising from a lying to sitting to standing position? So that gives us a lot of information to be able to target that plan of care that would enhance their mobility. Okay, so take a few moments and I want you to identify which areas in this concept map align with the following aspects of the clinical judgment model. So, which box aligns with noticing? And we've kind of, from the very beginning of the semester, have brought this to the forefront to help everyone to really hone those clinical judgment skills. So, what box aligns with interpreting? Are we to that phase yet? So here's a hint for you. So, what information must the nurse have to make sense of what the data is telling us in the assessment? So, we know assessment is the noticing stage, and how we interpret that is based upon all of these different aspects of knowledge, experience, what I know about the standards, and my attitudes specific to the topic that we're talking about, which is exercise and activity, but it could be applied to any problem or health maintenance, health promotion type situation that we're dealing with patient care. So, what information must I know to make sense of this data? Well, I have to know that normal activity needs for the patient's developmental stage. I need to know what normal activity patterns is. Do I need to know physical and emotional effects of exercise? Absolutely. I also need to know I need to apply professional standards, such as what we just discussed with the mobility assessment tool. That would be a professional standard. And all of that together helps us to use that clinical judgment, starting with the noticing, assessment, interpreting. I'm analyzing all of this data that I've collected on my patient, both subjective and objective, physical assessment, looking at psychosocial and cultural, just everything to analyze that and then start interpreting it and moving to planning. Okay, let's look at a case study. And we're going to look at Mr. Smith. And he is a 72-year-old African American who is hospitalized for surgery on his right knee. He's related this problem with his knee to previous sports injuries. So at one point in time, he was probably very active. He first sought medical advice and treatment about 6 years ago, and he's tried many types of treatments, including physical therapy, rest, pain medication. His only preoperative medication is ibuprofen, and he takes 600 milligrams every 6 to 8 hours. And that is quite a bit, actually. He and his wife are very active, so that's falls in his favor. So I want you to think about this. Um, will he need to go to rehabilitation after surgery? And what concerns do you have for this patient? So I want to recommend this. Get a colored marker or pen or something. And I know many of you print out your PowerPoints, and if even if you don't print them out, you can highlight different words using just the PowerPoint itself. So, for example, when I go to highlight, his age is important. His ethnicity is important. So I want you to pull out those important features as we go throughout the rest of the semester and you talk about case studies in my presentations and in Professor Cooper's presentations, is to pull out those key information. So we're gathering data is what we're doing, and we're noticing different things that might be important in developing a plan of care. Okay, so Marilyn is his nurse. She just finished rotating through the general surgery unit and is spending the rest of the 6 weeks of her rotation on the orthopedic um, part of the hospital. And she's been assigned to Mr. Smith through his surgery and his rehabilitation. So she prepares to assess Mr. Smith, and she has a sound knowledge of musculoskeletal anatomy and physiology and understands the components of exercise physiology. Marilyn knows that it's important to assist Mr. Smith in prompt, immediate post op recovery and to engage him in a steady, progressive physical therapy program. So, even though physical therapy is intimately involved with the care with this patient, remember it's the nurse that kind of manages the entire holistic situation. So, looking at it holistically and working with different types of collaborative healthcare providers. So, Mr. Smith, he's hesitant to ambulate and he uses his continuous passive motion machine, which is a machine that's commonly used with knee surgery. He rates his pain as a 6 to 7 on a scale of 0 to 10 and is using a patient controlled analgesic pump, or that's a kind of IV pump that the patient can push a controller and a dose of medication will be delivered intravenously to help control pain. So the patient has control of that. His degree of knee flexion is now 70 degrees, and he can ambulate 10 feet with a walker, but he describes the muscle in his right leg as feeling weak and tired after walking just that short distance. So 10 feet's not really very far. Marilyn also observes Mr. Smith using the walker incorrectly. So, what do you think Mr. Smith's nursing diagnosis problem statement should be? Well, here's some choices. So it's time to start thinking about the problem statement for this patient. And I have expanded that problem statement to include what is called a three-part nursing diagnosis problem statement. So each component of the problem statement has a related to and an as evidenced by, which forms the fully constructed problem. So I have chosen activity intolerance based upon the fact that he um, can't walk very far with his walker, and he's not using the walker incorrectly, which leads me to believe that he has some activity intolerance. So as he continues to walk using that walker, maybe he slacks a little bit on his technique that he's using um, with that walker. Now, it's not that pain's not important because that's part of the problem, but right now, let's focus on activity intolerance because we the main goal for this patient is getting him home and getting him back to his as close as possible to his active lifestyle that we can. So I've expanded on this activity intolerance problem statement, and I've included related to physical deconditioning. So he has not been able to use that right leg for a while. So the muscles in his right leg have been what we call deconditioned, and he may have lost a little bit of muscle mass. So when we talk about muscles and activity and exercise, the more you do that, the better. So you will prevent any type of deconditioning. Now, that's as evidenced by his weakened muscles in his right leg, and he gets tired after walking. So let's go back to our situation. So he described that the muscle in his right leg is feeling weak, and he also expressed he was tired. So that's um, data that we have used in the as evidence based to prove that he's generally physically deconditioned, and activity intolerance is one of many problems that this gentleman has. So I want you to pause the video here and try to create your own problem statement using this three-part system. But I want you to try to pull out data that would be supportive of an acute pain problem statement. All right, so we have our problem statement. Now we're going to go forward with making some goals and outcomes for our patients. So we know we want to improve or maintain, at minimum, maintain, their motor function and independence. Remember, it's very important um, to promote our patients' self-efficacy and confidence. Um, in doing so, we enhance the psychological uh, a component of the patient's well being. We want to set priorities, so we got to take into account what's the most immediate need. Now, we haven't talked a lot about setting priorities up to this point, but Maslow's hierarchy of need is a great way to be able to understand setting of priorities. So keep that in the back of your mind and moving forward. And as we do move forward in the semester and in your program, um, setting priorities will become more and more important for your understanding. Teamwork and collaboration is very important in providing and planning for the care. So we want to make sure we're involving the appropriate disciplines such as physical and occupational therapists. Physical therapists mainly work on the movement aspect of care, and occupational therapists can help the patient with such things as um, being able to feed themselves, to be able to put their socks on. So, those activities of daily living or instrumental activities of daily living. All right, let's go back to our case study, and I've created some goals for this patient. And that would be Mr. Smith has a tolerable pain level, and who determines that tolerable pain level? Well, that is Mr. Smith himself. So he's determined he is comfortable with ambulation if we can keep his pain between 2 and 3 on that 0 to 10 scale. We want him to gain the most optimal functioning as possible for his right knee so he can become more and more independent. And we have determined our measurable goal will be for him to ambulate 50 to 75 feet with the aid of a walker without reports of increased fatigue. We've also want him to reach a minimum of 90-degree flexion in that right knee by the time of discharge. That will help his flexibility in the movement of that knee. And then, of course, using his walker properly when he's ambulating. So maybe we do a return demonstration of proper use of a walker. So educating him and then having him return demonstrate. So, physical therapists are best equipped to identify the specific exercises a patient should perform. Occupational therapists, they help the patient with adaptive devices and ADLs, as I previously mentioned. But sometimes long term rehabilitation is necessary. So, long term being outside of, say, the acute care area. We want to start discharge planning from the hospital the second the patient is entering into the hospital. So that is always on our mind of all the things that we can do to help get that patient moving towards discharge. Examples of this would include what are their expectations in regards to physical activity or their readiness to exercise, what their hopes are for discharge, like our patient, Mr. Smith. So we involve the patient and their family in that conversation to help him determine, yes, I think I can reasonably walk 50 to 70 feet with my walker, and that gives that patient a goal in doing that. But we do that in tandem with the patient, and that helps in individualizing that plan of care. So we're meeting the actual needs of the patient, and the patient's a big part of that. All right, let's do a quick check. And here's your answer. So the answer is focused upon the specific problem identified in the question, and that is going back to the question. So we have this patient with a long history of arthritis. We've got some inflammation maybe going on in the knee. And the question is asking to determine the degree of limitation the nurse should assess. So I'm thinking, okay, this is a joint we're dealing with. So range of joint motion. We're not going to assess posture or activity tolerance or body mechanics because that won't help us in determining the range of motion for the patient's knee. It's the range of motion that should be determined prior to addressing posture, activity tolerance, and body mechanics. Helping a patient to walk can be more complicated than you think. When we're talking about patients in such settings as acute care, this can be a very unsafe endeavor if you don't take proper precautions. For example, we want to make sure that we're very astute in our evaluation of the environment for safety. We want to make sure that we're helping that patient into a sitting position first, not just, getting straight up out of the bed. We have them dangle their legs over the side of the bed for 1 to 2 minutes before sitting because changes in blood pressure can occur from a lying to a sitting to a standing position. So we would want to try to prevent that. And that change in blood pressure is actually called orthostatic hypotension. So essentially, a patient can drop their blood pressure by at least 20 um, millimeters of mercury or more, even when they rise out of a lying position all the way up to a standing and even to a sitting position for that matter. So we want to be cognizant of that. We want to help support their waist because their center of gravity still remains at midline, and we do this by application of a gait belt. But understanding that a gait belt is not used for lifting or carrying a patient by the waist, it's just a method of stabilizing. So, there's a point of reference that you are helping stabilize that patient physically. If you ever run into a situation where a patient, you're walking a patient, for example, you want to be assured that you're using safe patient handling techniques. Um, you want to be sure that the patient's wearing supportive non-skid shoes. Uh, that's another aspect of maintaining that safe patient environment. Nurses and nurse techs and other healthcare individuals can be seriously injured if a patient falls. So there's a technique to helping a patient to, uh, brace their fall without injuring yourself and without injuring the patient. You'll be taught that technique in the lab setting. All right, let's go back to Mr. Smith. And Marilyn wants to help Mr. Smith with ambulation and strength training. To implement her plan of care, she encourages him to use his PCA pump, so that's his pain medication, before he ambulates. That helps to bring that pain level down to a reasonable level so he can ambulate with minimal pain. We explain why he should sit in the bed and dangle his legs before standing to ambulate because of those changes in his potential changes to his blood pressure. And we want to make sure that he understands he's got, we want to reinforcing realistic increments. So he's not going to go from 10 feet to 75 feet in one day. So we increase his walking distance gradually in realistic increments. And then we talk to him about exercise tolerance. So we know that gradually increasing physical activity and setting realistic goals will encourage exercise tolerance over time. So he can have the ability to, lengthen the how many feet that he's walking at any given time. So, as part of this teaching process, I, as the nurse or Marilyn, knows that we have access to um, experts in the field of exercise and mobility, and that's the physical therapist. So, the physical therapist comes and provides instruction for the patient on how to properly use that walker, and we reinforce that by, demonstrating those principles as well and being knowledgeable in those same principles that the physical therapist is teaching the patient, and constantly reinforcing um, those principles and providing instruction or written instructions for using an assistive device. And there are many assistive devices that a patient has access to and that we can teach our patient and help them with. For example, walkers, like we previously mentioned with Mr. Smith, but also canes. Crutches are used many times when patients need assistance with ambulation. And there are certain things that we need to know about basic crutch training and how to appropriately measure for crutch size and gait. There's a 2, 3, and 4-point type gait, how they can safely ascend and descend stairs and sitting down in a chair. So, with your clinical modules, the clinical modules go through this, and you'll be learning about this in lab as well. But just to touch base, the basic crutch stance is a tripod position. So that is basically when the crutches are placed about 6 inches in front of a person, and about 6 inches to the side of each foot. Now, the axilla or the underarm area should never bear any weight on the crutch. That's not the purpose of the crutch being underneath the arm. So the patient assumes a tripod position before they even start to think about walking, using either the 2, 3, or 4-point gait. Climbing stairs, you must use a staircase with railing. That's the safest way for a patient to ascend stairs and descend stairs. Um, Falling is a huge risk when you're helping a patient learn to navigate stairs, and for a patient that's navigating stairs by themselves. And the reason why is because they get out of balance pretty easily, trying to manipulate the crutches and walk up the stairs or down the stairs. So you want to be sure there are no obstacles on the stairs or near the stairs. For example, um, my great grandmother, she used to collect newspapers, and she would always place them on the stairs. I don't know why, but that posed a huge hazard to my great grandfather. So, want to make sure that the stairs are clear and you have a good handrail for support. When you're having the patient ascend and descend stairs, you want to make sure that they transfer their body weight to the crutch while holding on the handrail with one hand. And you always want to stay with the patient, holding them with a gait belt to help their center of gravity and their balance. Then the patient supports their weight evenly between the handrail and the crutch. Um, the patient then places a little bit of weight on the crutch and then steps on the first step with the weight bearing foot or the stronger leg. We have the patient get his or her balance before they move forward from there, and then they're asked to straighten their good knee and push down on the crutch and lift their body weight so that they bring their affected leg and the crutch up the stair. And we always want to make sure the crutch tip is completely on the stair, not partially hanging over, but right smack dab in the middle of the stair. And then you just basically repeat that until the patient has climbed to the top of the stairs. Now, when they're descending stairs, they're even at more risk for falling. So you want to use extreme caution, caution them not to hop, but to make sure that the crutch tip is completely on the stair. They have good balance. They're taking their time to descend the stairs. Now, sitting in a chair can be particularly difficult with people who are paraplegic or people where both legs are affected by mobility issues. A lot of times, these patients will wear a weight supportive type brace plus use crutches. And how you want to assist them to sit in a chair is the patient holds the crutches in the hand on their stronger side. So, well, that could be neither side in the case of a paraplegic. So, that can be quite difficult. All right, here's a great picture, and this picture is actually out of your book, of a 2, 3, and 4-point gate. And you'll notice the solid color is shows the weight bearing in each phase. So the solid foot and the solid crutch tips. Now we know that many chronic illnesses um, can be greatly impacted by the restoration of activity. And we know that exercise has dramatic cardiac benefits, and also exercise has systemic benefits or affects all body systems. So I don't particularly feel it's important for you right now to understand these subheadings to each of these benefits, such as C reactive protein and um, calcium handling and all of that. But you do need to know, okay, so for cardiac benefits, I know that my heart's function um, is greatly affected positively by exercise, that exercise creates what we call this protective environment for the heart. It can actually improve circulation, which is macrovascular. It can of the heart, so that's circulation to the heart. It can improve overall vascular circulation, and also the systemic effects of exercise, such as decreasing the problems with type 2 diabetes. And even if a patient has type 2 diabetes, it can dramatically stabilize um, hemoglobin A1C, which is kind of a long term measurement of blood glucose. It can decrease body mass index, which further stabilizes blood glucose and enhances our body's ability to use insulin. It can also lower cholesterol, which is dyslipidemia, and lowering cholesterol and triglycerides, and reduces inflammation, which inflammation is a systemic problem. And inflammation itself, which you'll soon learn about in adult health, can affect all body systems. And some minds of thought consider inflammation kind of the base culprit of a lot of our chronic diseases that we have now. And all of these listed, inflammation has a part to play. So anything we can do to decrease that inflammation will only help us. Okay, let's go back and look through the eyes of the patient. So, is the patient in our case study? Is there is Mr. Smith's expectations being met? You think? So, what are our patient outcomes? Can we make comparisons with baseline measures? Can we consider standards for physical activity performance? So, we're reflecting upon all of this, knowing and experiencing, and then knowing our standards and our attitudes. So, we can compare the actual outcomes with our expected outcomes and cycle through that plan of care again if those outcomes aren't meeting our benchmarks. So while many of the nursing skills that you're being taught in this course seem pretty basic, don't discount the use of algorithms. So this is an algorithm, and it's provided in your text, and there are several of these in there. Algorithms and the use of these are becoming more and more standard of practice for nursing. Um, for example, the BLS, basic life support, CPR type algorithms. And I could just go on and on, but they are becoming the standard of care. Um, Plus, you have to think about it this way: even simple things like transferring a patient from a seated position, there are many points of decisions that occur while you're doing this activity for your patient. So, sometimes we have to dial it back a notch and look at this very simplistic. And that's what algorithms are, very helpful way of doing that. They take a complex problem or a complex decision, and they break it down into little smaller and smaller kind of decision making aspects. So, like, we start here. We're thinking about transferring to a seated position. So, I start here. The first question I'm going to ask myself was, is this patient cooperative or not? And trust me, that can really make a difference in, how you go about doing this very simple task. So, things such as understanding the impact of why I choose to attempt to ambulate a patient that cannot bear weight can have drastic consequences. If my practice as a nurse is not deliberate and my clinical judgment not sound, and algorithms can help you to be deliberate and help you to have sound clinical judgment. All right, going back to our case study. So we've evaluated the plan of care. She asked Mr. Smith to rate his level of pain, and we got a good level of pain. Looking at that range of motion, he's using this continuous passive motion machine, and he's been walking, and we're watching that. And here is his assessment findings. So we ask ourselves, is he under control with his pain? Is he able to ambulate with minimal discomfort? Is he using his continuous passive motion or CPM machine, which is helping his range of motion? So all of these questions we're asking, and it looks like to me he's headed down the right road. So it's been 5 weeks, and Mr. Smith's progressed so well that he is on his road to recovery and being discharged from the hospital. But Mr. Smith, he became progressively steady to increase both his weight bearing range of motion. Mr. Smith expected the pain to be completely resolved on hospital discharge and not to follow into physical therapy. So Marilyn and the physical therapist worked with Mr. Smith and his orthopedic surgeon to identify more appropriate pain control measures so that he can we can implement that, and once implemented he can have more controlled pain and increased strength in his legs so he can return to his racquetball and tennis game. All right, so here's some key points related to this topic and related to safety. So we always know a patient's level of mobility, and how we do that, we use assessment tools such as the Banner assessment tool. We assess their risks for activity tolerance. We look at transferring steps before beginning any type of transfer. So we mentally go through that. We play that in our head like a movie. So step 1, step 2, step 3. We stand on their unaffected side. I know that seems counterintuitive, but um, the rationale for that is we don't want to bear the entire weight of the patient should the patient begin to fall. Uh, we use transfer equipment when we need to. We raise the side rail on the opposite side of the bed. We arrange for that equipment. We make sure we're evaluating body alignment so we don't get injured and our patient doesn't get injured. And we certainly want to understand the workings of any equipment that we use before we even bring it into the patient's room. Okay, and that's all that I have for this chapter. And I'll have the next chapter for you shortly. Thank you very much.